Todd. Thanks for joining us.
Oh, thank you for asking.
Yeah. Well, I'm excited to share revenue cycle management, which is such a riveting topic for private medical practices. Especially for those of us who are into the numbers, we do actually love it. I love seeing the analytics and some of the great things that can come about from it. But maybe share a little bit about your background and what you did previously and kind of what you're doing today.
Sure. Yeah. Thank you. I started in healthcare in 2014. Prior to that, I worked for 15 to 20 years in different industrial companies, very large, very efficient companies like Honeywell, among others. And so my immersion into healthcare was actually as the interim CFO of a Navajo-owned critical access hospital in the middle of the Navajo Nation. So about as different a healthcare environment as you can have. And then, but I ended up moving into practice management, specifically in the allergy and immunology world in 2016. Was recruited to be the practice administrator at Arizona Asthma and Allergy Institute out in Phoenix, and then worked for a couple years with Allergy Partners as well, doing acquisitions, opening new clinics, things like that. And then started my own company beginning of last year to work with called Complete Allergy and Asthma. And the purpose of the company was to work with small, medium-sized allergy practices, helping them become more efficient, clean up their revenue cycle, just improve their productivity across the board. And for those that wanted to stay independent, which is a big challenge for private practice today. And that's kind of what drew me into working a lot in the revenue cycle world, because that seems to be the area where there's the opportunity for the biggest impact quickly for practices.
Yeah. Sounds a little bit like me. I came from a big corporate environment, and while it does not have all the efficiencies you can put in, but you saw a lot of great things, right? You had a lot of resources, you had a lot more money, you had a lot more people. And so you were able to really take to fruition these ideas of making things more efficient.
It was, as I tell people, I went from the Six Sigma world to the far less than Six Sigma world when it came to healthcare in general. It's just not a very efficient, business at the end of the day. So
sure. I always try to frame it a little bit more positive as just lots of ripe for opportunity, right? You can kind of look as an advisor, you're like, okay, let's just change this one simple thing. Sometimes it's simple. And, sometimes it's definitely not, but it's like, okay, let me just apply one or two of these simple tweaks and, we can kind of get this thing going and get it rolling in the right direction.
I literally had that conversation about an hour ago with one of the practices that we work with. It's actually a pretty large practice that we work with. There's lots of opportunities for improvement. Yeah.
Yeah. Well, tell me, like, for our non-physician, listeners, how do you define revenue cycle management? Because to me, it can be lots and lots of different types of things.
Okay, sure. Yeah, I look at it from kind of the beginning to the end. So everything, the beginning being, when the patient comes in and registers, are we capturing their insurance information, their demographic information correctly? Is everything entered into the system accurately? One wrong letter in a member ID can cause a claim to be denied because, of course, it doesn't go to the right person or it doesn't go to a valid number. All the way through, the next step is really, what I would call seeing the patient and then entering the charges for what is, what that patient was seen for the day. So it might be one charge. It might be, an office visit, it might be some procedures, might be some combination of those things. And then the next piece is, pushing those claims across to the insurance companies. And practices do that a number of different ways in terms of, do they kind of scrub those things before they get sent across, or do they just kind of take the data that was input by the physician and send it straight over? And then you get to the back end where it's, either your claim gets paid or it doesn't. If it doesn't get paid, you're working those denied claims to try to bring as many of those dollars in, because every denied claim, you've done the work, you've done the hard part, you've spent the money on whatever, and the staff time, you might as well get paid for the work. And so that's a huge component to the ultimate success of the practice. And then the last piece is making sure that the patient's account balances are correct. So what they call the payment posting process, where you say, okay, $100 went to Todd's account for these procedures, so that when you mail them a statement, they're not screaming at you because you have an inaccurate patient statement. That's a really good way to not get paid in your practice, is by giving patients inaccurate information. So I view it from the kind of the patient intake phase all the way through making sure that all the money gets put into the right accounts.
And I like that you started that very first interaction with the patient of verifying, because honestly, as an accountant, I get really focused on the dollars, as soon as a dollar has happened. But that is such a critical phase in getting that right, doing it before they arrive, generally happening again when they're right in front of you. That piece really starts this efficiency. That's where you're able to add some Six Sigma and some really efficient, we're going to do it like this every single time, and build out some of those processes.
Yeah, exactly.
What do you see as some of the biggest challenges in this cycle for private medical practices today?
Yeah, I would say the thing that we see the most, and we work with over a dozen practices now, so plus I have my experience from the past and so forth, but I'd say the number one issue is a lot of them don't really know what they should be paid, what that in terminology, in kind of revenue cycle terminology, is the fee schedule. So if, for example, United Healthcare says you should be paid $110 for a certain level of office visit, you want to have that information. You want to be able to then, after you have that information, compare it to what you're actually being paid, right? So to get a sense for how efficient your overall revenue cycle is, that's kind of maybe I think the most valuable individual metric that there is comparing what you're collecting versus what you should be paid. And hopefully that's as close to 100% as possible. It will almost never be 100%, just because ultimately some things will get denied for one reason or another. But the closer that is to the 100%, that ultimately in the end, the more effective your overall process is. So I would say that's the number one thing. And then I'd say another key factor is a lot of physician owners and practice managers aren't aware or don't believe that they have the ability to negotiate higher reimbursement rates from insurance companies. We get involved in that work with almost every practice that we engage with, simply because, in many cases, they won't have touched their contracts for a decade or more. And your costs are going up. The insurance companies, of course, their premiums are going up. We all know that, personally, because we pay those premiums, most of us do anyway, on our own insurance. And so, okay, if the cost of everything is going up, well, ultimately then that means the physician or the physician practice also needs a raise. And so just knowing that that's available, I'd say those are the two biggest things that we run into.
And when you're looking at how much you should be paid, you're comparing kind of the contracted amount versus what you actually collected. Do you see I think that's hard for everyone. I see it across specialties. Do you think it's more difficult in certain specialties versus others, or are you kind of consistently seeing that as a pain point for multiple specialties?
Yeah, I would say it's across the board. It'll be different procedure codes or individual CPT codes that it might impact one practice or another. But for example, one area that's pretty common would be specialties like obviously allergy, oncology, rheumatology. Those that do a lot of injected drugs that are relatively expensive, they will probably share a lot more common characteristics than maybe some of the surgical specialties, which might have other things where claims are being disputed or denied. So, for example, in something like surgery, you might see more prior denials based on, hey, we think this prior authorization wasn't valid. You didn't get the permission of the insurance company, of all people, to do the procedure. I guess the simplest way to summarize it is, generally speaking, the most valuable codes for a specialty tend to be the ones that are disputed the most, which kind of makes sense if you think about it. The insurance companies are going to focus most on where they're spending most of the money with your practice.
Sure.
So, yeah.
And when we're working with teams, we're looking at their profitability by CPT code, and we see the same thing. It's big dollars on both sides. The insurance companies do like to deny things, even when you have the prior approval, prior authorization. And so working, that's like when you talk about processes, having a denial process and keeping track of that, depending on the size of your practice, could be a full-time job for someone as well, depending on what you're seeing. And sometimes I think, like, why do we have a whole head count that's just working on this one thing? But there's a lot of dollars at stake, and it's a very important role, depending on the size of the practice.
Yeah, just real quickly to build on that point. I've seen a lot of practices that will underspend in that area, like working those denied claims. And I try to present it to people this way. Let's say it's a $5 million per year practice, and maybe they've got, let's say in a best case, maybe 10% of the claims are getting denied initially, right? So there's $500,000 of potential money sitting out there. And, a good insurance collector, someone that's good at working those claims, you might spend $60,000 or something like that for a really good person to work that. It's like, is the $60,000 worth, collecting $500,000? That's an easy answer, right? The answer is yes. And even if they can't collect all of it, let's say they collect half of it. I mean, the point is you want to have somebody working that. It's going to be a very strong return on investment for the practice owner. And of course you could go too far, right? You could spend too much on it. But if the issue, as you talk to your team, if the issue is, boy, we don't have enough time to work all the denied claims, there's a couple things to work on, but one of which would be just make sure you have enough people to work the denied claims. And then on the other side, the answer would be make sure that you're entering the claims accurately and with the right kind of documentation, clinical documentation. So when you do have a denied claim and you send the records in, everything is easy to identify. It's like, okay, they did this. Okay, we denied it initially. Now we'll pay it. So it's usually cleaning up the front end and cleaning up the back end. Yeah.
Yes, I think there's a special place in billing heaven for people who love working denials. Their expertise, I think they may be former IRS type agent people. Like, they are meticulous. They are on it. Not all billers are created equal. And like you said, there's some people that are really great at the front end and they're catching errors, or, they're able to work that piece. But the denial piece is generally one of your higher level experts, right? Like, they're having to dig into why something was denied. They have to go, I don't want to say we have to retrain our physicians, but sometimes we have to change our process flow or work on our notes in a different way so that we're, more easily documenting and getting things through on the first time. So, for our denied billers that work denials, definitely appreciated and a value of the practice.
No doubt. Yeah. It's, in fact, yeah, the most highly functioning revenue cycle processes I've seen, the team working the denials will give that feedback to the physicians and those that are entering the charges to say, hey, I'll pick on a different payer, with United Healthcare, this is what they require in terms of documentation, or they only allow a certain number of a particular code to be done in a year or a day or something like that, where another insurance company may have different rules. So ultimately, I've seen practices where they'll build a grid around the most important codes that they're billing by insurance company to say, okay, here's the rules for Aetna, here's the rules for Blue Cross, here's the rules for Cigna, and so forth, so that they at least try to prevent as many initial errors as possible. Yeah.
And these grids, agree. I've seen the grid. It's an Excel spreadsheet. It doesn't have to sometimes I love tools and I love technology, but sometimes we can overcomplicate things. This does not have to be overcomplicated. It's just an Excel spreadsheet. In most cases, I see some physicians have it laminated and it's on their, they walk it around with them so they can easily consult it. So yeah, we don't always have to overcomplicate kind of how we're doing this.
Yeah.
Earlier you had mentioned contract negotiations and you had mentioned 10 years, which is kind of common. Like, I think practice managers and physicians, you're just so busy running your practice. You are just like, sure, this contract automatically renews, or I've never thought about even going back to, any of the carriers. What is, like, if you had to tell someone a best practice, how often should they be reaching out to look at negotiating their contracts? I mean, it takes a tremendous amount of time. So being cognizant of the resources of the practice.
Yeah. So I would say that if you haven't negotiated them in at least 3 years, you would want to go ahead and try to start immediately with all of at least the major commercial payers, Medicare Advantage plans, and so forth. As a general rule of thumb, most insurance contracts, either the initial term or when you negotiate a new set of rates, will renew for a 3-year period. And so they tend to be on an initial 3-year cycle, and most of those will then kind of go evergreen, if you will, on an annual basis thereafter. So initially it'll be 3 years, and then a yearly renewal, auto renewal, if nobody intervenes. And typically you'll have to intervene within 90 days, before 90 days of when it would terminate. So easiest way to answer the question would be the typical cycle, if you're on top of it, will be about once every 3 years with each of your major payers. But if you haven't done it for at least 3 years, then all of them are probably eligible for at least an effort. And what you will find is, some payers will engage, some will blow you off, some you'll kind of have to cajole into negotiating with you. And we could talk about that later. But as a general rule of thumb, you'd want to reach out to all of them at least once every 2 to 3 years to re-engage the process.
And normally I look at stack ranking, either the dollars or number of interactions, or, I'm going to go after the largest one first because maybe it's going to take me the longest. And then maybe some of the smaller ones, like you said, there's a lot of cajoling as part of this process, and honestly just being stubborn and persistent, and the squeaky wheel gets the cheese, unfortunately. I feel like there's a lot of stiff arming from the other side for a variety of reasons, but you do have to stay on top of it. I feel myself sometimes I'm like getting very corporate, like, per my last email on this date at this time, you said you would get back to me on 2 p.m. on a Thursday, and you have not responded. So it is a lot of documentation and a lot of follow-up. What are some of the terms, besides price? Because I think we're all looking at contracted amounts, but are there other terms to consider when you're negotiating?
Yeah, I would say I can give you a recent example and then generalize it. One thing that people don't tend to look much at, of course, people will focus on the actual rates, right? And at the end of the day, that's probably
number one. Getting paid is the most important, but yes, there's some other things that
how much you're getting paid is typically number one. And a lot of practices, if you were to ask them, we'll also think about like what I would call the dispute resolution process. So if a claim is denied, how quickly do you have to respond back to the carrier in order to dispute the claim? What's that process like? How long can it go on? If you agree to disagree in the end, what's the resolution process? So that's an important thing, but a lot of practices will think about that. And honestly, most payer contracts, sometimes they will make that time period too short. But otherwise, I would say generally the contracts aren't written that poorly in that dispute resolution piece. A part that is often overlooked, which we came upon very recently with one of the carriers, is kind of what I would call the liability side of things. And what I mean there is some of the commercial insurance companies will, they're operating a business, they're trying to maximize their own profitability and income and revenue, and they may have some policies that they want to implement through the practice around things like drugs that might be prescribed by the physician, perhaps having to go to their specialty pharmacy, or any number of things. The point is that if a payer is saying, "Hey, we're going to want you to follow our processes," and let's say that the physician disagrees with those processes or doesn't think it's black and white, that they think, "Hey, our specialty says we should do things this way, and you're telling me we should do things this way." You want to be sure to insist, and this will get really challenging in the discussion, but you will want to go back, push back on that carrier and say, hey, if you're going to tell me how to do things, then you need to share in the liability if something goes wrong with a process or a workflow that you're prescribing to me. They will definitely raise eyebrows when you do. You'll probably be in the 1% of people who would push back on that. But it's really essential because, in general, what they will try to do is say, we want you to do things the way we tell you to do them, but we're not practicing medicine, so you're going to have all the liability for it. And in the specialty that I know best, which is allergy and asthma, if a patient self-administers a drug and has a bad reaction at home because the payer wants it to be done at home, well, I don't want to be the only one on the hook for that problem. If I, kind of, if you will, consent to allow that to happen, I want to make it known that, hey, there's somebody else that they can go, that they can
reach back to, for sure. And how amenable are they to this? I mean,
they're not really at all.
Right.
But you at least want to be able to raise the issue. One, it shows them, I think, that, hey, they're dealing with a sophisticated, person on the other end, which is helpful in a lot of ways. But two, you can decide, how much leverage do you want to try to have? And of course, a lot of times it does come down to leverage. You may, for example, if it's your most important payer and you're a very small practice in a big market, you may not have really much negotiating leverage at all. On the other hand, if you happen to have a larger practice and have even in a given market, let's say it's Tulsa, Oklahoma, as an example, we don't work with anybody in Oklahoma. But if you had someone, if you had a certain specialty where you had 70% of the specialists in that specialty in Tulsa, and the payer was trying to, be heavy-handed in what they do, you do have some negotiating leverage because they want your specialty in their network. They really don't want to go out of network, and you just might have to, kind of hold your ground and as part of the negotiating process. And maybe you'll eventually concede on some point like that, but that might help you get a couple % more in reimbursement, which at least then you can buy higher level of malpractice coverage,
Sure. Absolutely. When you were saying that, I was like, well, who's the insurer for the insurer when we potentially get back to this reach back point? So I don't know that part. Yeah. I'm not a lawyer and I don't know that piece, but that was kind of where I went.
I'm not.
I think they have plenty of funds to cover themselves. So
yes.
What are there any other terms that you try to always, make sure you're including for your clients?
One thing, one thing, for example, with a new practice, let's say someone is breaking out on their own. One thing to try to keep in mind would be, the initial contract that you're offered typically will be kind of fairly low rates and essentially
vanilla, right? Like vanilla, you just get what you get.
Yeah, like bad vanilla, right? Like not even good vanilla. It's worth an effort to try to negotiate that initial fee schedule. Of course, it's helpful to have some sort of data to say, okay, well, here's why it should be a little bit higher. They probably won't roll over on that, but it's at least worth asking. And then if to the extent they won't, what you may want to try to do is try to limit the initial term from kind of a standard 3-year initial term to maybe 2-year. It's tough to get to 1, but if you could get to 2-year, at least it gets you into that negotiation window sooner, which then gets you, an opportunity once you've proven yourself as a practice and that you have some patients, that are going through that carrier. It gives you, if nothing else, just an earlier bite at the apple for negotiating better rates. So that would be a tip that I would have for someone kind of starting up their own practice.
And building on someone starting up their own practice, what if they were part of a practice or maybe part of a hospital group and now are on their own? Do you think they have a little bit more power if they kind of anticipate bringing over a patient base or they have, experience in the profession versus, I'm a newly minted doctor starting my own practice?
Yeah, I would say they have slightly more, but not a lot.
Okay. So it is practice based more so than like the physician.
Yeah, generally. The exception might be if you had something very specific that you could provide in writing to the insurance company to say, hey, yes, I'm moving from ABC multi-specialty group to my own practice. And oh, by the way, they've agreed and I'm taking, my 4,000 patients with me. That would give you at least a little, again, marginal leverage, but at least a little bit of leverage to say, hey, here's what I was being paid by CPT code. I'd like to be as close to that as possible, given that it's really just the same thing. One thing to look out for, however, for the physician that is doing that, you want to do the research before you make the move. And what I mean here is, in some markets, particularly ones that the carriers think are saturated, they may say that their panel is closed. And so this is not revenue cycle specifically, but it's, I think, a good point is to say, hey, double check and make sure that Blue Cross will accept you, or UHC or United Healthcare or whoever it is, at least for the major payers in your market. Because if you find out that they're not going to accept you, you may need to try to work out a different sort of deal with the group that you're hoping to leave from. Maybe you can continue to work under their, maybe
you're a satellite office and you just get a little bit more independence.
Work out something kind of entrepreneurial. Yeah.
Well, so I see physicians sometimes try to do a little bit of this on their own or engage with their practice manager, and not that they're not good negotiators, but like they've got to be focused on their practice, right? Like it's a big time consuming commitment to start these. And again, you probably won't start all contracts at one time and, recycle them every 2 to 3 years, pick them a little bit. But how can practices work? Like, how do they get engaged with a company like yours? And what does your process, look like in starting to tackle this for clinics?
Sure. Yeah. I think maybe just a general statement I'd make would be the value of working with a consultant would be, they have the experience, right? I mean, the same way a physician goes through years and years of training, if the consultant or the group that is going to work with you has a lot of experience negotiating contracts, that's really helpful because they understand how the game is played, how you might have to push a lot harder than you think. Like, for example, you may want to threaten that you're willing to go out of network with a carrier. And of course, they might call that bluff if it is really a bluff and say, okay, fine, we're happy to let you go. But in a lot of cases, they really want to have, a pretty complete portfolio of providers. So that would be one thing. The other is, so I would say generally that would be something that you would want to think about. And then to your point, right, how much time and how much effort, right? So people that negotiate insurance contracts come in all different, let's say, at all different price points, at all different cost levels. Some can be very expensive and they're very good. Some can be quite inexpensive relative to the return on investment. It's worth talking to several to get an idea of how they do what they do, their process, how long it takes, and kind of how they charge for the work that they do.
I've seen several different models on charging, right? I'm like, oh, okay, that's a different model. This is a flat fee. This is a monthly something. This is a percentage. I think it is creative in how different companies are charging people.
Yeah, you've hit the main options. It's either kind of pay by the hour, it's pay as a percent of like the improvement that is achieved. Some of it is just kind of a monthly, almost like a retainer type model. But if you think about the time, on the physician side of things in particular, if you can be seeing patients and generating, let's say $200 or $300 or $500 an hour doing your work, you just have to decide, okay, is it sort of the same way you would hire a CPA, the same way you would hire an attorney? You might look at it and say, okay, well, this is an expense that if I'm doing this work, I'm not seeing patients, and that's a trade-off. Sort of like the comment I made earlier about underfunding, under-resourcing your revenue cycle team, right? It's the exact same mentality for a physician who's busy, has a life outside of work. and is capable of generating, quite a good income on an hourly
I'm all
basis.
for using experts, and there definitely is a cost, but I think they're better. I don't cut my own hair. I don't pull my own teeth. I've done there's a reason they're an expert. They have that expertise, just like I would go to a physician or someone in a specialty. They have crafted that. They are the expert in that. I have heard some carriers are like, I will not talk to a third party. I will only contract with the physician. I will only accept emails or calls. Do you ever get feedback like that from carriers?
I've received feedback like that. There are pretty easy workarounds. For example, let me say this up front. I have yet to have someone that say I absolutely won't work with a consultant. I know in some of the larger groups that can be more common. We in the way that we engage with clients, we have a two-way non-disclosure agreement already baked into our agreement. And so, there have been cases where we've worked behind the scenes, almost like, Cyrano whispering in the ear, and helping craft, the emails, the letters, the spreadsheets and things like that. And then, handing those to the physician owner or the practice administrator to say, hey, put your name on this, but here's what I think we should say. And we work through that. By the way, we work through that with every client. So we don't ever say, okay, here's what we're going to do with United Healthcare or whoever. We say, hey, based on the data, here's what we think we should do. You as the owner, this is really important for practice owners. You should own the decision-making process as to the strategy being executed. You rely on the consultant to say, hey, this is where I think we should go with this particular carrier. But ultimately, it is your business, and you want to own that decision. So it's important to stay engaged, but then let the consultant do the work. It's like, okay, agree on the tactics, agree on the strategy, agree on the end goal, and then let them do their work. But if they have to send everything out under your name, it's there are ways to work.
We figure it out. Yes.
Yeah.
Well, you said based on the data. Tell me a little bit about, if you were taking on my clinic, what would it look like for you to data mine, and how would you decide who to go after, which carrier to target first or which CPT code? How do you dig in and figure some of those things out?
Sure. Yeah. The first thing we do is, if we don't have them, we work with the practice, and we can do this legwork if necessary. We get the contracts and we get the existing fee schedules. Those are kind of essential to have. If you have one that's important and for whatever reason you can't get your hands on that data, the next thing we do turn to, and we turn to this regardless, is we will run a report out of most practice management systems. There's a report that will be essentially your charges, what did you bill by CPT code, by insurance company, and what did you collect as well, and how many units did you bill? And we can use that data almost as a proxy. If you take the payments divided by the units, that gives you a rate of what you actually collected. We don't necessarily know that you collected 100%. You might have collected 90% or 96% or whatever it was of what you should have, but it'll give you at least a rough idea of what your fee schedule would look like. Then the next step we would do is we will benchmark that. So we'll benchmark it with kind of, I'll say, easily free publicly available data, which would be like the Medicare fee schedule. We'll look at like, what are you getting from Aetna, compare that to Medicare for your market to get a sense for, are you above Medicare, below Medicare, and how much? It's important to understand, depending on the state you're in, if you were in Florida or Alabama, you're probably going to be below Medicare rates. And if you happen to be maybe in Montana, you're probably above Medicare rates. And these rates have everything to do with competition and supply and demand. You're dealing with very, very sophisticated large companies with the insurance companies. So they know all this information. But the next step is to continue to benchmark it in whatever ways you can. So the good news is, due to, I can't remember the name of the act, the Transparency and Data Act or something like that a few years ago.
Something similar to that. Yes.
Yeah. The insurance companies are actually required to make publicly available all of their fee schedules with every practice that they work with. they put them in really large, difficult to manage files that only like data mining experts that have big racks of servers can get at. But, there are companies out there, be happy
There's
to,
a variety of companies that, they'll sell
that
you the
you
data
can,
or they'll put it in a user interface that makes it actually usable. Yes.
Yeah, you can essentially buy the data for your competition in the area, and you could do it by specialty specifically. So you could then have your fee schedule, and you could have 2 or 3 or 5 competitor fee schedules. And if it turns out you're the lowest paid, you can now safely share that data with the carrier and say, look, I went to this publicly available data that is your own fee schedules, and it looks like you're paying my competitors 15% more. A group I was working with earlier today, we had that conversation with one of the major carriers. And it was shocking to them because they're actually the larger practice out of the group, but they had the worst fee schedule. In most cases, it's the other way around. But regardless, being able to use that information to then paint a data-driven story as to why your rates need to be higher. The carrier isn't going to care that you hadn't bothered to negotiate for the past 10 years. They're going to view that as your fault, not theirs. So it's tough to rely just on that. But if you have 2 or 3 other really good benchmarks to say, well, here's how far below market I am, it at least paints a much better case. And I would say generally, not always, the worse your fee schedule is, the bigger increase that you're able to capture from that insurance company. If you happen to have the best fee schedule and it happens to be better than the other major carriers in your market, those are going to be very difficult to negotiate as a small or medium-sized practice. You may get a few percentage points increase if you really haggle hard, or they really need you because you represent, half the providers in a given specialty in a given market. But basically, the good news is the worse your fee schedule is, the bigger the fix can be when you actually take the time to negotiate it.
Yeah. I'm going to have to reframe that. That might be the bigger opportunity. Are there other things to look at besides price? Like, do you help calculate hospitalization rates and other type of metrics? I mean, what if you're a physician and you're a fabulous physician, you're near the top end, which you totally deserve, and you have lower incidence of X, less hospitalizations? Do you bring that to the table as part of this discussion with carriers?
That's a great question. In certain specialties, there are different quality metrics that you can use, some of which come from the payer themselves. We had the experience once when I was working in Arizona with United Healthcare. I'll give them credit. They actually looked at some of those sorts of things, like with our asthma patients, for example. What was the prevalence of hospitalization or emergency room visits, urgent care visits? And for the doctors who were doing well on that, they provided various incentives, even for the patient, where it might be a slightly lower copay, for that office visit. If you see the doctor who, if you will, handles asthma better than the other doctors, there'll be top doc awards, sometimes again from the carriers, and sometimes just from like the publications and so forth. But using any kind of quality data as well will be very helpful. For our company, at this point, we don't deal with a lot of inpatient related or readmission type of issues, but we have used those quality metrics around outcomes for these outpatient clinics, which we have worked with, to at least marginally paint the better picture, right? But for the most part, in my experience, it'll generally be driven by, okay, if your rates are bad relative to some really good benchmarks, then that's generally what's going to do it. But it does help build the case. And if I had more experience on, hospital readmissions and things like that, I could speak to it, but I just don't have that experience.
How long can a physician in a practice expect for this process to take? I mean, I feel like I hear anecdotes of like eternity. And then, sometimes, for some of them, some smaller carriers, it's, 60, 90 days, and like they have a more efficient process.
Yeah, I would say a good rule of thumb is probably about 6 months.
Okay.
And what I mean there is, that's assuming they engage. Well, first off, we know who we need to engage with. In some cases, we have to do the digging to find out who the provider rep is or whatever they call it within a given carrier. And then, then we have to get them to engage. And then they almost always are going to ask us from a process perspective, well, what do you want, right? They don't want to make the first offer. They want us to make the first offer. And so we tell them what we want. And then there's a haggling process or a back and forth process that typically takes 45 to 60 days if you stay on top of it and you're kind of pushing it along and not trying to drag it out forever. And then the carrier will take things back into their side and they will either draft an amendment or a whole new contract, which then you'll want to review. Because if it's a really old contract, they'll typically want to put it on new paper. And you'll want to read that before you sign it, by the way. And then it'll take them anywhere from 45 to 60 days for them to load the new fee schedule in, test it against some practice claims to make sure it's going to pay at the proper rates and so forth. So but that's a long answer to say that it normally takes around 6 months. I've seen it be done in 4 to 5 months. I've seen it take a year or more, depending on how complex it is, how many locations it might be, certainly multi-specialty groups. The more complex it is, obviously, it almost exponentially grows in time. So.
Well, if a practice was going to kind of have like one or two things that they could tackle on their own to get ready to work, with someone like yourself or begin this process, what are one or two things you would encourage them to do today to be ready to start this process?
Yeah. First, definitely gather all your fee schedules and contracts. And
it's surprising to me. I think it's a record keeping thing. I've had to request quite a few contracts for practices. Their practice manager has changed or they've moved to all digital and they don't know where it's stored. So I agree. And they do not turn those contracts around to you quickly, right? Like you put in a request and it could be 60 days before they send you back a piece of paper that you signed, 10 years ago.
Yeah. And yes, easily. There's no incentive, right? If you're the carrier, there's no incentive to help you engage with them sooner when they know you probably want it because you're thinking about negotiating your contract. Another thing would be, that a practice can do, we can do this as well. We can do it pretty efficiently, but would be get a sense for what you're being paid today. Look at those charges and payments and it's not hard to calculate what you're actually getting paid per unit, per insurance. It's sometimes hard to find the report, but if you're not sure how to run the report, that would be a good thing to ask an expert for, ask the software company to help you understand. And then a last thing, somewhat related to that would be, I think it's helpful to know for the claims that are being denied, like actually how much was written off. And where I'm going with this is if you're having trouble collecting all that you should, that is, again, it's subjective, but it's I'll say a more substantive subjective point sometimes to bring up in the negotiation. What I mean here is if the carrier is notoriously difficult when it comes to fighting you on paying claims, I will share that data when in the negotiation process and say, hey, with the same doctors and APPs and the same patient population, our claims are being, we're having a much higher percentage of claims initially denied, a much higher percentage of record requests, we have to put more work in to collect the money from you than we do from someone else. And here's how much more work it is. You can actually quantify it, right? And even if it's just a measure of the denied claims, you could say, hey, on average, we're getting 10% of them denied with every other carrier. With you, it's 26%, So again, at least on the margin, you're using that information to say, hey, because of that, that's another reason that you need to give us a little extra on the fee schedule, because unless you want to be like everybody else and be more reasonable in your claim review, we need more because you basically make us wait longer for our cash and you make it ultimately less we collect less from you than we do every other carrier, and here's the data, so
I think the data is the critical point, and that's where professionals like you and I mean, again, I said we were data nerds here at the beginning. I mean, those data points tell the story. And so it sounds like you're taking the data of what's actually happening in the practice, what's happening with competitors, and taking all these different pieces, and you're putting together the story, the compelling story of why you should be paid more than you're being paid now. What it means to the practice, how easy they are to work with. And you're taking that and yes, it's a negotiation. It is a back and forth, but it's a compelling story, a factual story of this is why I'm coming back to you. This is why this is important to our practice and why, this should be done.
Exactly. Because otherwise you're just asking, you know what I mean? And you may get somewhere with that, but it'll probably be more of a nominal increase. And with me saying all that, there's no guarantee with the perfect case of data that the carrier will even engage with you, right? They may just blow you off. And then you just have to decide how hard a ball do you want to play with them. But without the data, they have all the data in the world on their side, and you want to bring as much that tells your story. You're building a case using data. And that's, from my experience, that's the best way to get, particularly for a small or medium-sized practice. If you're an 800-pound gorilla, the biggest hospital or health system in, the state of Michigan, you have a lot of clout when it comes to negotiating, but those are bruising negotiations as well when they negotiate with the carriers, because you're talking billions of dollars, flowing through those systems. Here, in a lot of private practices, you're kind of a rounding error in their system. And so, but you want to fight for your share. And so, in my experience, if you had 5 top carriers you were trying to negotiate with and a really good case, you'd probably maybe only get 3 of them. I've seen 4 out of 5. I've seen as low as 1 out of 5. We haven't been shut out in our negotiations, but we've never gotten all of them to agree to an increase either. So that's something, I guess, one of the last points maybe to keep in mind is that, you may put in a lot of work and get nowhere with a couple payers, but you really have to just keep trying. And if it didn't work this year, go back next year, keep going back. Yeah.
My husband is an attorney, and he made the mistake when our daughter was 4 to tell her that everything was a negotiation. And so I feel like the year of 4, nap time, dinner, activities, everything was a negotiation. But in this case, it really is. It's not, price, terms. I think you've brought up some excellent points. Todd, if our listeners are interested in learning more about your background or connecting with your firm, what's the best way for them to connect?
Sure. Yeah, we have a website. We have 2 websites, actually. One that is specific for contract negotiations and another one that's more about practice management and consulting services, which is where we started. What we found was we started to have so many requests, even from people outside of the specialty allergy that I grew up in, so to speak, that we created a separate business line. So the negotiation one is Medi Negotiate, so MEDI negotiate.com. And the one that talks more about some of the consulting services that we offer, which we can certainly do for, I would say, almost any sort of outpatient clinic. It's a fairly catchy URL if you're in the allergy space. It's called breathecomplete.com. Or just Todd.McGee at breathecomplete.com. That's an easy email. And, would love to work with anybody that, or just have, we start off with an initial consultation. There's no charge. It's just try to understand what are your concerns? What are you trying to accomplish? What's keeping you up at night as a practice owner, or practice manager, and, to see if we think we can help. It's a small team, but we have a lot of experience, on IT systems. If you want to potentially sell your practice, we're good at valuation of practices, obviously contract negotiations, and then just practice workflows. How, if you want to see more patients with the same staff, what can be done? A lot of times we can help you figure that out. So, just reach out to us. Yeah.
Well, and I'll be sure to put all of those in our show notes. I think Todd's a professional like myself. We talk with business owners and practice owners like, here's your problem. And sometimes I'm not the right fit for a variety of reasons, but we both have strong networks in the space of like, okay, this person is best at helping you with this, or this person might be able to help you with this. Again, there's a lot both of us can do. But if we don't know the answer to the problem, we've both got networks that we can reach out and help someone find the right resource. So thank you for sharing that. And thank you for being a guest today. I really appreciate it.
Thanks for joining me on Profits in Practice. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with a fellow physician. Your financial wellness is just as important as your patient's health, and we're here to help you thrive. Connect with us via our website at webcfo.com. Thanks for joining us.